Hello everyone, this is Dr. Ochoa for Pathway to Wholeness. In this video, we'll be discussing exercise, its importance, and our pre-participation protocol. The importance of exercise can be summarized in the following two observations. Number one is that exercise reduces the risk of dying of any cause. This is referred to as a reduction in the risk of all-cause mortality. Second is that exercise is a principal modality for the prevention and the management of all manner of chronic disease that we see every day. Things like heart disease, diabetes, obesity, chronic pain, cancer, osteoporosis, and even dementia. So what are the guidelines for exercise? For adults, this is about 150 minutes of moderate intensity exercise per week, or 75 minutes of high intensity exercise, and add to this 2 sessions of resistance training per week. For children, this is even more. This is children between the ages of 5 and 17 years of age, 1 hour per day, in addition to 3 sessions of muscle strengthening activity per week. So, do you meet this recommendation? If not, you're not alone. Only 1 in 4 men and 1 in 5 women in adolescence are meeting this recommendation. So, I hope that by the end of this video, we'll all have a better appreciation of the importance of exercise advocacy for our practice. So without further delay, our video on exercise, consider this a part 1. So here is an interesting graph from the U.S. Department of Health and Human Services from the Physical Activity Guidelines for Americans, 2nd edition, 2018. And what you see illustrated here is a thing referred to as hazard ratio of mortality. So that may sound confusing, but if you imagine in any given study where death from any cause is registered and you are identifying people according to the amount of exercise that they do, the group of persons who does not exercise will have the highest mortality rate, and that's given as 1 or 100% in the far left of the graph. As you go to the right, you see that there's a decline in the risk. So by the time people are in the 150 to 300 minute range of moderate physical activity per week, they've already attained around 70% of the benefit in terms of risk reduction. So let's look at fitness as an indicator of risk of death. So in 2018, published in JAMA, here's a study of 122,000 patients who were referred to a medical center for exercise testing. So because everyone did the exercise on a treadmill, you were able to identify their level of fitness, and what they did was they identified 5 different groups. Those with the lowest level of fitness, or less than 25th percentile. Then the next group is below average, above average, high, and then the last group, the elite group, who are about the top 2% of performers. So looking at this graph, I draw your attention first to compare going from low fitness to below average fitness. There is already a 50% reduction in the risk of all-cause mortality. This is a 2-fold decline in risk of dying of anything. Continuing along, you see that the graph continues to show a progressive reduction in mortality, and by the time you're at the elite group, the risk of dying is 80% lower in that group compared to the lowest fitness group. And seen another way, this would represent a 5-fold increase in mortality rate in the low fitness group versus the elite group. This illustration is from the study that we were referencing earlier, and I draw your attention first to where it says group comparison. And from what we just discussed, when you look at the mortality of the low versus elite group, the low group had a 5-fold increase in mortality, or 5x. So looking at the hazard ratio as expressed in this study here, this is a factor of increased risk rather than the fraction of risk in the graph. Going down further then, let's look at low versus below average. And as we noticed, By the time you went from low to below average, your rate was reduced by 50%, or looked at another way, a twofold increase in the death rate in the low versus the average group. So now let's go down one more, and this is where it really matters in regards to this illustration. So let's look at below average versus above average. So the below average compared to above average would have or confer about a 1.4x increase in mortality rate. But now look at the illustration here on the right side where I've drawn a red line. And if you go up, you see that a 1.4x increase in mortality rate is comparable to diabetes, is comparable to smoking, and is actually higher than existing coronary disease. It's higher than hypertension. The exception here is that in end-stage renal disease, that confers a much higher risk overall of mortality compared to these other factors. So in summary, the higher your fitness, the lower your risk of dying. And there appears to be no upper limit to the benefit of fitness on survival. Most of the benefit is experienced early, and in this study, almost a 50% reduction in mortality going from low to below average performance as measured on treadmill testing. Lastly, getting people to move more may be the single greatest intervention to improve longevity. We should encourage people to reach the highest level of fitness they can reasonably achieve. So let's look at fitness in a different way through VO2 max as a measure of cardiorespiratory fitness. And this reflects the maximal rate of oxygen use during exertion. So cardiorespiratory fitness declines with age as much as 10% per year and 15% per year or more after the age of 50. Peak muscle mass is experienced in our late 20s. After the age of 50, loss of mass develops at a rate of 0.5% to 1% per year. Muscle loss is measurable within 1 week in even healthy individuals who are experimentally immobilized. Clinically, we see this often in people who are in a cast and come out of the cast and have a much smaller limb, arm, etc. after the period of immobilization. The factors above mentioned help to explain the risk in older adults of the following: risk of injury, of fractures, and risk to insulin resistance. So we sometimes identify older individuals who are lean that have lost a lot of lean body mass, and as the muscle is the principal storehouse of glucose in the form of glycogen, the less muscle you have, the higher your risk of an elevated glucose in the form of diabetes or prediabetes. This also explains that terrible decline we often see in people who are hospitalized for any reason, an acute hip fracture, a stroke, other reasons for hospitalization. And the classic example here is that the 1-year mortality rate in persons who are over 65 in this country after a hip fracture is 1 in 3. So I direct your attention now to the graph on the right, where VO2 max is illustrated by different categories. And everyone sees a decline, obviously, over time. But if you take the lowest fitness group, see what they're declining into. This is becoming a scenario where people, as they get older, are now unable to do things that they could easily do when they were younger or in their middle age. This decline is particularly apparent in the last decade of life. I think I understand now why, when I was younger, as a physician, I didn't really get why it was that someone could walk into the hospital and after a period of stay, be incapable of walking out of the hospital. It just seems so strange, but I think with what I understand now, it makes all the sense in the world. This table is from the second edition of Physical Activity Guidelines for Americans. And if I can summarize, here are some of the benefits. For cancer, there's a lower risk of bladder, breast, colon, esophagus, stomach, endometrium, kidney, and lung cancers. Elsewhere, I've read that not just the incidence, but also the recurrence and the survival of cancer is improved. What are some brain benefits? Lower risk of dementia, improved cognition. There are benefits to the bone with reduced fracture risk. For chronic disease, as we mentioned, there's a reduction of risk. There's improvements in control of things like diabetes and hypertension. For our geriatric population, there is a lower risk of falls, and there's a lower risk of injury should you fall. As you know, there are several areas that we focus on in lifestyle medicine, including sleep, nutrition, and mental health, and all of these have a relationship or are improved by exercise. As you may recall in our lecture on sleep, we mentioned a study where two groups of individuals who were calorie restricted for a period of time. One was allowed to sleep normally, the other was sleep restricted by about 4 hours per day. And at the end of the study period, about 70% of the weight loss that was achieved in the sleep restriction group was muscle loss. So this is terrible. This is precisely what you didn't want to lose. You didn't want to lose your lean body mass. Looking at exercise and nutrition, there's better regulation of satiety. That is, you're more in tune with how full you are. There's improved control in glucose, like you might see in someone trying to prevent diabetes or trying to control their diabetes. There's an increased sensitivity to dietary protein, and that means that when we do the resistance training, now we are going to be even more responsive to what protein we do consume. And in mental health, there's reduced anxiety and a reduction in the risk of depression. So let's look at exercise intensity. You might have heard of rate of perceived exertion, which is a scale from 1 to 10. How about a percent of maximum heart rate? More practically, you're looking at the so-called talk test. And so looking at moderate intensity activity, this is activity we can do and speak but not sing. At vigorous intensity activity, we can speak with significant difficulty in short sentences or words alone. And at near maximal to maximal activity, we're unable to speak. Now, because this concept of METs is important elsewhere, let's just look at this in a little bit more detail. So, metabolic equivalent of tasks, or METs. And METs represent an energy value with one corresponding to the energy used at rest. Sedentary behavior is defined as any waking, low-energy behavior, such as sitting or lying down, watching TV, and that would be or correspond to a MET of less than or equal to 1.5. So, is pre-participation evaluation necessary? Why is this even relevant? So, someone's going to be concerned that if you advise an individual to do exercise, they're going to have something terrible happen to them. We really ought to be thinking about what terrible things are going to happen if they actually don't exercise. But if you're looking at the risk, what are the principal drivers of that risk during significant effort? Number one is sedentary status. Number two is sudden vigorous physical exertion, especially in someone who is sedentary. A third is existing cardiovascular disease, known or unknown. And lastly, HCM, or hypertrophic cardiomyopathy, which affects about 1 in 500 persons. Now, when you look at certain studies, and in this one referenced a study looking at sudden cardiac death in marathon runners, the most frequent findings in those individuals were HCM and CVD. So for the clinicians in the audience, persons who do experience a fatal or non-fatal event during exercise often have experienced symptoms in the days or weeks prior to the event. So, the overall risk of exercise-related sudden cardiac death in the general population is very low. In one study published in Circulation 2014, it was 1 in 565,000 person hours. One of the illustrations in the publication from the Circulation article in 2014 looks at the risk of a heart attack in terms of relative risk in active individuals versus sedentary. And you see that for a bout of intense activity, the highest risk in the dashed red lines are for sedentary subjects. Now the baseline risk is lower in people who are active, and it continues to decline depending on how many days of intense activity they're doing per week, 1 to 2 versus 3 to 4 versus 5. And in this graph, they're qualifying high intensity as at or above 6 METs. So here's a question for you all. Walking. Does walking require pre-participation evaluation? So there's a resource there, and this resource is relevant to our pre-participation protocol. The short answer to this question, of course, is no, they don't need any evaluation. But the long answer is as follows. So, the population with the greatest potential for benefit in risk reduction are sedentary individuals in the lowest fitness category, recalling from our previous study that compared to them, even below average fitness group individuals had a nearly 50% reduction in all-cause mortality. Slow walking in the range of 1 to 2 miles an hour is a sufficient training stimulus to raise people from the lowest fitness category. In the vast majority of persons, the cardiovascular benefits of exercise, of course, far exceed the risks. Light to moderate exercise in persons without symptoms do not generally need to consult a provider unless they have specific questions. So what about stress testing? Is it ever necessary pre-participation? And here guidelines are not all in agreement. Looking at the ACC, AHA, which is American College of Cardiology and American Heart Association, few data exist to support the use of testing or physician consultation to reduce the risk of mortality during exercise. Despite this, the ACC and AHA guidelines suggest testing persons with known CVD who plan to participate in vigorous intensity activity. So, what about the USPSTF, the U.S. Preventive Service Task Force 2018? The task force found insufficient evidence to assess the balance of benefits and harms of screening with EKG or stress testing to prevent CVD events in asymptomatic adults and intermediate or high risk of CVD events. So they weren't saying not to evaluate these persons, but they didn't find sufficient evidence to make this compelling. And those persons were without symptoms and at intermediate or high risk. What they did state further was that they recommended against screening if a person had no symptoms and was at low risk. So I'd like you to take a peek at the illustration here to help understand this concept. And this is one rationale for why these guidelines don't agree. So, in stress testing, true positives require a significant flow-limiting coronary lesion. So that is, if I have only a very partly obstructed vessel, I'm never going to experience any symptoms during significant effort. It has to be pretty substantial for me to start to feel anything. Now, second point. Most heart attacks occur in mild to moderate coronary lesions, not in severe lesions. So this is an interesting paradox, that we're going to be impressed by somebody's very substantial blockage, say of 80%. But most of the heart attacks are occurring in plaques that are of a smaller size. So with that said, we have individuals with existing heart disease who are going to have a cardiac event but are not going to register an abnormal stress test. All that to say that unless someone is experiencing any symptoms, they're unlikely to have a positive stress test. So in summary, and this is to our providers here, recommend persons for stress testing when indicated generally, not for exercise pre-participation considerations alone. So let's look at a description of our pre-participation protocol. And the first question is, Does the patient already regularly exercise and is without symptoms regardless of known disease? If the answer to this question is yes, then there's no further screening that's required. Now, what's asymptomatic, or in other words, without symptoms? That would be qualified as an absence of chest pain or shortness of breath or exertional symptoms. So it's intuitive about maybe chest pain, but what about things that come on when you're physically active? So the clinicians know this, but there are people who have so-called anginal equivalents, and by the time someone is doing something very substantially physically, they might experience chest pain, neck pain, back pain. Sometimes they'll even experience heartburn. They may experience fainting or near faint or severe fatigue. So, in summary, if someone says to you, when I climb upstairs I get heartburn, you'll have reason to suspect that that's probably not heartburn. Question 2. Sedentary individuals starting an exercise program. So for that category, we'll start with our PAR-Q Plus app. And that would be the Physical Activity Readiness Questionnaire. So the PAR-Q Plus could be used in all persons and may identify those who are symptomatic. Now, for anyone who's doing this evaluation or who has administered a PAR-Q Plus, you will refer to a pathway to wholeness provider in the event that 1. There's an abnormal PAR-Q, 2. that the patient is symptomatic, and 3. if they have known disease and are sedentary. And the known disease here would be CVD, kidney disease, diabetes. Now, to our providers, we refer persons outside of the practice who have indications for CVD testing. So I would encourage you to try and get a grasp of the verbal description in the previous slide, but the cheat sheet is as follows. And once again, does the patient already regularly exercise and is without symptoms? If the answer is yes, no further screening is required. Our PAR-Q is optional at that point. If the answer is no, you administer a PAR-Q. If the patient has symptoms, refer to a provider. If the patient is asymptomatic, the next question is, does the patient have CVD, kidney disease, or diabetes? Notice that by this point in the algorithm, this represents a group that is sedentary but without symptoms. So if they do have CVD, kidney disease, or diabetes, refer to a provider. And finally, if they don't, no further screening is required. Thank you so much for your attention. I hope you can take away something positive from this presentation. I believe that exercise is such a vital aspect to our health and to our life, and we now have some rationale for why it will be a focus of our practice at Pathway to Wholeness.